Coming up today, she spotted her own cancer. Now she's keeping it in check. One woman's path from ovarian cancer diagnosis to survivorship. Good morning. I'm Jessica Lovell, and welcome to the Morning Medical Update. With any cancer, early detection saves lives. But with ovarian cancer, there isn't an effective screening method, which means ovarian cancer often goes undetected until it reaches an advanced stage. With me today is an expert in ovarian and other gynecologic cancers, Dr. Andrea Jewell. She is the Division Director of Gynecologic Oncology at the University of Kansas Cancer Center. Good morning, Dr. Jewell. Good to have you.
Good morning. Thank you. Happy to be here.
Great to have you. We're also joined by one of Dr. Jewell's patients, Kristen Baker. We had met Kristen about a year ago when she came onto our program to discuss how she saw her own tumor before she ever saw a doctor. And today we're catching up and learning more about life after cancer treatment. Kristen, good to see you.
Thank you.
Looking great and feeling great, I take it?
Yes, I'm feeling wonderful.
Well, we're glad to do kind of a where are you now and with us today. But tell us this story again. It was really fascinating when Dr. Jewell told us about your story, but you're an ultrasound tech.
Yes.
But not here at the health system, but tell us this story about how you spotted your own cancer.
So I work at a small rural hospital, and we had a student. We had a break in our schedule, and the best way to teach an ultrasound student is to have hands-on. So I was like, let's go practice working on an abdomen, scanning an abdomen. And we go to my room, she puts the probe down, and we just see fluid all over. And I was like, this isn't right. So then I told her, go get one of my coworkers, and I just kind of scanned myself, and I was like, oh, this doesn't look good at all. So then I went to my primary care doctor after that.
I mean, you telling that story kind of makes my heart stop. I mean, like, it sounds like a scene from a movie, Dr. Jewell.
Yeah.
Like, I mean, that doesn't really happen.
No, it was when I got the referral and I was reading to prep the note and talk to her and, okay, this is our treatment plan. And I'm reading it and I was like, what? Okay, so she was ultrasounding her own abdomen and found this, which I think is a very, you talked about, there's not a great way to screen for this. And a lot of people call this, you have such vague symptoms. And that's exactly, we've talked about this so much. Yeah, I was kind of bloated. Yeah, I went to a barbecue and maybe I ate something and I thought my stomach was off. But in reality, she had tons of fluid in her abdomen, a cancer that had grown and spread to other places, but really vague symptoms.
Does that sound about right, Kristen, on those symptoms?
Yes. I really didn't have any symptoms other than just like regular GI issues and a little bloating and then maybe just feeling a little full, but I didn't really think too much about it or anything.
Gosh, don't we all feel like that?
That's what I say, like intermittently, right? If we did biopsies or CAT scans every time someone felt bloated or like, oh, my appetite's off today, right? We'd be doing that all the time.
Exactly. Go back to that moment when you saw that fluid. I mean, you're used to looking at things, but when you saw that on yourself, that just must have been really surreal.
Yeah, I was like, is this really happening? Is this real life? Like I just kind of went into like a delusion, like, oh, everything's fine. Like, you know what I mean? You just never expect to see something like that on yourself.
But I love that you got a second set of eyes by going to get one of your colleagues to look at it. You also decided to get a set of eyes, like Dr. Jewell. You decided to come to the University of Kansas Cancer Center. What was it like when you first met Dr. Jewell?
I was nervous coming in. I never thought I would see an oncologist at 29. But as soon as I met her, she was great. She was wonderful, so nice. She told me exactly like what the treatment plan is and like was very positive about everything. She was never like a Debbie Downer. She was always like uplifting, like, you got this, you can do it, and everything else.
And you said you had read through that chart ahead of meeting Kristen. Were you kind of getting ahead of a plan of what you were thinking?
Yeah, when we talk about ovarian cancer and advanced ovarian cancer, data does tell us there are, standard ways that we should be addressing these. And so when patients come in, I sort of know, okay, well, these are sort of a few of the different paths that we might go down. And whenever I have a new patient, I always look at their CAT scans, I look at their records, I look at their biopsies. So I sort of in my head have a prelim idea of, okay, this is what path I think we're going to take. But obviously I meet them, I talk to them, I see where they're at. So yeah.
Let's look at one of those scans. This was an abdominal scan. What are we seeing here?
these are always so hard to describe, especially without having a pointer or something. But, you know, essentially, we're not seeing as much of the fluid here on the scan. We see some of it. There's like a little bit of those bright white areas. That's some pockets of fluid that were in her abdomen. But those are also some of the masses that are in her abdomen. And so that upper abdominal, the top one you're looking at that's right underneath her liver, that was a large mass in her omentum, which is this fatty apron that lays on top of your bowel and is a really common place that cancer spread to. But essentially what this cat's showing us is that we have masses that are not just on the ovaries. She had masses that had spread to other places in her abdomen, and those were things that we needed to think about when coming up with a plan to treat her cancer.
Why is it so common for that, that spread when it comes to ovarian cancer?
So ovarian cancers seed the abdomen. And so what I sort of describe is, you know, you think of your abdomen, it has a lining called the peritoneum, and that's sort of like a saran wrap sac that keeps all your organs and everything inside. And for whatever reason, ovarian cancers, when they shed from the ovaries and spread to other places, they implant onto the lining of the abdomen and they cause it to become leaky and to make all that extra fluid. Ovarian cancers can spread outside of the abdomen, but most commonly these are cancers that stay inside the abdomen, and they're relatively bulky and they kind of just like to attach themselves on the lining and the outside of places in the abdomen. And so that's why we know that aggressive surgery can be really beneficial in these cancers, because they're not necessarily deeply invasive in a lot of other places. And they're also really responsive to chemotherapy. So these are cancers that pretty commonly we start with chemotherapy to shrink things so that we can then do an aggressive surgery later on.
So what was Kristen's treatment plan? And was she considered advanced when you saw her?
She was advanced, and the overwhelming majority of ovarian cancer patients are advanced stage when we diagnose them. And that's always that's something I talk about a lot when I meet patients, because when they hear that stage 3 or stage 4, that feels catastrophic. But even stage 3 and stage 4 patients can still respond really well to chemotherapy, and we still can expect really great responses. So she did. She had cancer that we felt like was in places that we didn't know if we were going to be able to take everything out safely in the upfront. And so rather than putting her through a surgery that may not have been optimal, we started with chemotherapy.
So it's so frustrating when we tell people, get your screenings, know your family history. And why do we not have a way to screen, get some sort of advance notice on this particular type of cancer?
Yeah. Agreed.
Why?
Yes,
Give me those answers.
you know, they even actually updated the guidelines now for patients with genetic mutations, that there's, even in those patients that are higher risk, we're not necessarily picking things up sooner by doing extra ultrasounds and getting extra lab tests. And that's why there are a lot of researchers working on what are better ways that we can diagnose these cancers. I myself work with some PhDs working on early screening for ovarian cancer, and are there blood tests, are there different things that we can be doing, because ultrasounds are not picking things up soon enough.
So let's say you have a family history. You get tested for like BRCA, that gene mutation. What does that mean? Okay, so you know you have that.
Yeah.
So then how would you ever even know that you could be at risk for, so now you know you might be at risk for it, but then how would you even know you would have it?
So right now the most effective thing that we have for risk reduction is risk reducing surgeries. And so that is a surgery where we talk about removing the ovaries at the time when people are done having kids, and then talking about hormone replacement and things like that after that. There's some newer data saying that it looks like we might be able to do surgery to remove fallopian tubes and then remove ovaries at the age of menopause. Obviously in someone like Kristen, though, unfortunately at 29, she wasn't at a place where she was going to want to have her ovaries or tubes taken out. And so she would have been someone that we need to come up with a better screening test and a blood test or something like that to give us more information.
So again, let's go back to those vague symptoms. What advice then do you give to somebody when it comes to these, we've talked about a lot of these GI issues, with colorectal cancer being on the rise. When people have these GI issues, when do they know to come to a doctor and start talking about that as a possible symptom of ovarian cancer? So
I normally say that, we all have bloating, we all have abdominal pain, we all have GI changes that happen. I normally say if you have something and it's persistent for 2 weeks, go and get checked out. So if we're like, you know what, I haven't bloated and it's been 2 weeks, I'm still bloated, or I have this pain, it's right here, it's not really getting better, it's been persistent. Those are all reasons I say to come in. My other big soapbox thing is if you have abdominal symptoms and no one does a pelvic exam, you need to keep going until a doctor does a pelvic exam. So your uterus and ovaries are right next to your rectum. They're right next to your bladder. If you have fibroids, if you have benign ovarian cysts, they can cause abdominal symptoms and changes. And I cannot tell you how many patients I have show up in my clinic who have gone to the emergency room, gone to their primary care doctor, having these persistent abdominal complaints, and no one has done a pelvic exam.
And I think we've talked about this last time you were on. Who should be doing that pelvic exam? Should you be going to a specialist?
So, there are family practice doctors that are very capable and comfortable doing pelvic exams. Some are not. I think essentially it's if your ER doctor or primary care doctor is saying, we don't feel comfortable doing a pelvic exam, or like we don't have enough skills to say if it's normal or abnormal, go to your primary GYN or find a GYN. I don't think you have to see a specialist. You don't have to see an oncologist. Primary GYNs are more than capable of knowing, hey, there's something abnormal going on in this exam. But that really is one of my soapbox saying. If you have abdominal symptoms and someone has not done a pelvic exam, then you need to keep going to get what is actually happening addressed.
You live on a soapbox, don't you? I think you do. You like it up there.
People get some opinions at dinner parties and whatnot.
They at the parties, I bet they do.
Yeah.
Kristen, let's talk good stuff. How do you describe the status of your cancer today?
Well, I'd say every appointment I go and see Dr. Jewell, there has been no signs of cancer or anything, so thank God. I would say NED, and I'm survivor. So.
No evidence of disease, as we say, NED and survivor. So, and you see each other about every 3 months.
Yes.
How long will that go on for?
So that's going to go on now for at least another year or two. So she just, and we'll talk about this a little bit more, she just finished her 2 years of maintenance therapy. So we did chemo, we did surgery, we did more chemo, and then we did maintenance therapy with her PARP inhibitor, and she just completed her 2 years of maintenance therapy. So she is now done with maintenance therapy, 2 years out from her initial treatment. So we'll still see her every few months.
So let's talk about these PARP inhibitors. Why does it need to be inhibited? Tell us about these and how does it help in the maintenance process?
Absolutely. So PARP is a way that your body has of repairing DNA damage. And so if you're taking a PARP inhibitor, what we're doing is we're inhibiting those cancer cells' ability to repair DNA damage. And what we know in BRCA patients is that type of mutation relies a lot on PARP to keep the cancer cells growing or for them to be able to repair themselves to regenerate. And so when we give BRCA patients a PARP inhibitor, those patients respond really well, meaning those PARP inhibitors really kill those cancer cells. And the goal of doing that maintenance therapy is if there's any microscopic cell left behind after we did chemo, after we did aggressive surgery, if there's any microscopic cell left behind, we give this pill therapy to help kill any cancer cell that thinks about wanting to wake up.
Is it only for maintenance, or could it be while going through chemo or immunotherapy?
So there have been a lot of clinical trials looking at combination of PARP inhibitors with other therapies. What we know is that PARP inhibitors with chemo are a little too toxic. Blood counts and side effects and things don't tolerate well. So that's why we look at this as doing for ovarian cancer as a maintenance therapy. Now, like I said, there are other clinical trials and things like that looking at combining PARP inhibitors with other targeted therapies, just not chemotherapy, and it's not the standard of care now and upfront.
Which one, I was going to say which one are you on, but it is which one were you on, because you just ended it. Tell us about that.
I was on the Lynparza, and I took 2 tablets twice daily.
Any type of side effects?
At first, it just kind of wore me out a little bit. I was a little tired, and then a little bit of nausea, but nothing too crazy or anything.
We always get thrilled when people are ending their, they ring the bell and they end their chemo and they complete their different treatments. But what does it mean to complete this maintenance treatment? How exciting is that, and what does that mean overall as your treatment journey?
I feel like such a relief. Like, it's been a whirlwind. I can't even believe I'm done. Like, I just feel like I finished a long marathon, and it's really crazy. Like, I'm just a weight off my shoulders.
It's nice, kind of like sweeped up everything, you know,
Yes.
kind of like everything, it kind of tied everything up with a bow there. Are there any side effects with that though? I mean, do people normally feel anything?
You know, most people tolerate them reasonably well. It is also PARP inhibitors, these pills, it's sort of about finding the right dose for each patient. So it is not uncommon that you hold treatment for a while to manage side effects. You may go down on the dose of the pills. And that's why I really try and tell patients, we just need to find the dose that works for you and what you're going to tolerate. Fatigue is the most common side effect. For some people, it's comparable to what chemo is like. And so some people, it really is difficult to get across that finish line because that's a long time, 2 years, if you're having significant side effects. Most people are kind of comparable to what she's describing with some GI side effects, the fatigue. It can affect your blood count still too. So we follow labs really closely, and that's another reason that we may hold doses. I think a lot of people, when they hear pill, they think, oh, this is going to be a lot easier than chemo.
Right.
And it can be, but there's still, a lot of side effects.
So have these maintenance medications, have they changed the outlook for ovarian cancer survivors, just in terms of like recurrence or quality of life?
They have. So when the first trial came out with Lynparza, following BRCA patients, that was the first time we were seeing ovarian cancer go away and in some patients not come back. So there are some patients on that initial trial that the cancer has still not come back. That has never happened before. So ovarian cancer, we have been pushing the finish line down a lot farther for patients, or survival, of making longer and longer overall survival. So, back in the 1980s, overall survival was 12 to 13 months. And then 10 years ago, we were looking at 5 or 6 years. So we moved that goalpost down, but it was still coming back. These PARP inhibitors are the first time we are seeing ovarian cancer go away in some patients and not come back.
In the long run, will these PARP inhibitors, will they keep working, or do patients build up a resistance to them?
That is something we're trying to figure out, honestly, because these are relatively newer medicines. And so we are now seeing patients that maybe they're coming back, the cancer 5 or 6 years later. Is there a benefit to doing these again? There's a lot of studies looking at that, and there's not a standard answer, I would say, right now. We don't know for sure. My hope is that this is going away, and she's going to be one of those patients that this has gone away and it's not going to come back.
Well, be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. All of that information is right there on your screen. Dr. Jewell, what are the biggest mental health challenges that you see, in particular in ovarian cancer patients after treatment, and then how do you address them?
Well, she's actually at a very interesting transition time period, and this is actually one of the times that we actually see the highest stress in cancer patients, and not for everyone. She's really happy and excited to be done with treatment, but when you're undergoing chemo, when you're doing maintenance therapy, you're doing something, right? Like, I am waking up every day, I am in this fight, I am fighting this cancer, let's do this. When you're done and we say, hey, you're in remission, now we're going to follow you in surveillance, that motivation of getting up every day and saying, well, this is what I'm doing to fight my cancer is gone. And so even though it's a really exciting transition, that a lot of patients, and it's very normal, feel an increased layer of anxiety at that time because they don't have that feeling of like, well, I'm doing this thing, I'm doing something.
That's really an interesting way. I've never thought about it like that.
Yeah.
Me either.
Do you feel that way? Or can you see where someone would feel that way?
She's like, now I do. Now
It's like,
I know. Now that you said that.
But you're right. They have something to get up, kind of like something that thing that they've been focusing on, and now that focus is gone. And while it's good news, now it's kind of glaring. But what are your thoughts on that, and just how have you been handling everything?
I feel like I love what I do. I love doing ultrasound, and I feel like I have a big purpose in doing that and helping others, and that gives me such joy and everything else that I don't necessarily feel like I have that anxiety. I feel like I just have one less thing I've got to do and more power to focus on what I love to do and help others and everything like that.
Yeah.
How important do you find just people's support system around them? Would you know how to support them, but then when you send them home to partners and spouses and families and colleagues, when you go back to work, it's just, it's so important.
It's hugely important. As you know from I mean, she not only had a husband and family who was supportive, she had a whole town rallied behind her. And that's always one of the things that we actually, when I meet patients for the first time, I sort of assess and talk to them, hey, who do you live with? Who's around? What is that? And that is something we think about in the back of our head as providers of, what do we need to maybe do a little bit of something extra, if this person doesn't have the support that they need to get through some of these things. So that is a really big thing. Here at KU, we have cancer therapists that they only see cancer patients. So totally normal to have stress, anxiety, depression, all the things you can imagine with a cancer diagnosis and chemo. So we have therapists that's what they do.
Did you utilize some of those services?
I actually did not. Like I said, I had a big support at home and everything. I had my wonderful husband who waited on me hand and foot, and then my whole family was there calling me, texting me, giving me positive thoughts. My coworkers were always rooting me on, so I had a big support system that I was so blessed to have.
You had that. Not everyone does, so it's nice to know that there's people who can fill in that gap for people who don't have that. But how did you just handle some of those days? I mean, when you weren't having an up day and then you're having those down days, what advice might you give to someone who's entering into this world and the unknowns?
Yeah, I actually I found a Facebook group for ovarian cancer patients and everything, and I call them my teal sisters. If I was having a day, they were having a day too. Somebody was, and you could always message them, and you get positive feedback from them. Or I would, if I wasn't up to talking to them, I just probably cuddle on the couch with my dogs, and they would just give me love. Or Will would just hey, what can I do to make your day? He would either go buy me flowers, something just to brighten up my day.
Just to perk you up.
Yes.
Was hair loss a big thing for you? I can't remember when we talked the first time. Was that an interesting path for you?
So
you shared this photo with us last time.
Yes, this photo.
You seem to be embracing that part of it.
Yes. So I took it as more of on a positive light. I took it as okay, this is my first step into getting better. And yes, some people have anxiety or get down about losing their hair, and I was too, but I was also I'm ready to get better, and then it'll come back and be fabulous, just as it was before. But I also included my family into it. I had my honorary nieces and nephews cut a piece of it, so they were all kind of a part of it and everything.
Well, you look gorgeous and looking fabulous.
Thank you.
You mentioned your teal sisters and just ovarian cancer support group. Dr. Jewell, I was going to ask you, do you find that just breast cancer survivors and ovarian cancer, that there's kind of that niche support for people who have these different types of cancers? That cancer is not just one size fits all, that you're going through different cancers and there's a very specific type of support that each type of person needs.
Well, and there's even different types of ovarian cancers, as I'm sure she knows from being on the group, where someone will say, oh, well, this is my chemo, or this is what we're doing, and they're like, oh, well, I have a different ovarian cancer, so I'm doing a different thing. So even within the type of cancers, there can be different treatments. We actually at KU have a women-to-women mentor group, and so where we pair patients, if you have a new diagnosis or a starting treatment, we can pair them with someone who has gone through that treatment before, and they can, some of these people, they talk on the phone, they Zoom, some of these people meet up for tea or coffee, so it's you can make that relationship what you want it to be. But I think it's very important, because there's stuff that you're going to talk about on a Facebook group of did you, is your skin doing this, or stuff that you may not say at the visit to say, oh, I don't want to ask Dr. Jewell that, or that seems like a silly question, but you feel more comfortable asking that on a group of, hey, are you guys having this as well? What's up?
Right, for sure. Any specific strategies, mindfulness that you used along the way that others might turn to? I know you said you reached out on social media. I say that's the positive power of social media.
Yes.
Kind of what helped hold you up?
Definitely my faith. My faith did, just knowing that I had God watching over me, and I had lots of people praying for me was a big thing. And just, again, like the support I had behind me, just rallying me through on the good days and bad days, is really what helped me get through.
And Will?
Yes.
That husband of yours?
Yes.
There he is. He's here with you today. So we always, I'm sure Dr. Jewell loves it when, you know, these folks that, you know, support them through their whole journey. It matters. Certainly does. We've got some really good questions coming in from our viewers this morning, so I want to get to those. Georgianne, good morning. She wants to know, is there still a higher risk of ovarian cancer for breast cancer survivors?
Well, so what we know at baseline is if you have a cancer diagnosis, another cancer diagnosis, the data tells us you are at slightly higher risk of developing other cancers. That being said, without having an inherited genetic mutation, just having a history of cancer, we wouldn't change your screening recommendations, meaning we'd still say get your colonoscopies, you know, follow up with your primary care. We wouldn't necessarily change what those recommendations are for screening. Unfortunately for ovarian cancer, there isn't a great way of screening. So for patients with inherited genetic mutations, we sometimes talk about ultrasounds and a tumor marker called CA-125. Just having a history of cancer, we wouldn't necessarily change that.
So kind of along the same lines, Jeremy is asking, is ovarian cancer one of those cancers that you can see if you're predisposed to through family history or genetic testing?
Correct, it is.
Okay.
And so we know that, you know, and I think we're seeing even more and more associations of ovarian cancers with genetic mutations. So it's a standard of care. All ovarian cancer patients should get genetic testing. So that's a standard of care and recommendation. And if you have a strong family history or people in your family that have a history of ovarian cancer, if those people are not alive anymore, we're recommending more and more that you should consider getting genetic testing because we may find something.
Kristen, did you have any family history? You did?
Yes, my mom had both breast cancer and kind of like the cousin to ovarian cancer. It's called primary peritoneal cancer.
Dr. Jewell, you had mentioned earlier different types of ovarian cancer, and Stu was asking, what are the different types of ovarian cancer, and what is the most common?
Yeah, so the most common is what Kristen had, and that's a serous epithelial type, and that's just what the cancer cells look like underneath the microscope, but that would be the description. So most ovarian cancers are epithelial, but there are germ cell tumors, there's borderline, there's low grade, there's different histologies. Histology means, again, what I said, what the cells look like underneath the microscope. And what we know more and more is that that is how we should be treating cancers. So again, 40 years ago, oh, you have ovarian cancer, this is what you get, you know, this is the treatment. Now what we know, okay, well, we need to be treating these of what they look like underneath the microscope. We need to be treating them by like how the tumor is going to respond, not just from where it's growing from.
Amy wants to know, how does menopause affect ovarian cancer or the treatment options? And does menopause increase your risk?
So, no, it doesn't increase your risk. We do see ovarian cancers more in menopausal patients, but just being menopausal does not increase your risk. I think just getting older increases your risk of developing any type of cancer. Menopause does not change how we would what we would recommend for treatment. Now, being premenopausal does change sometimes how we talk about treatment options and what we do afterwards. So, for example, she's on hormone replacement therapy. I wouldn't put a menopausal patient on hormone replacement therapy afterwards. But that's a conversation with us of saying risk versus benefits. Side effects of being menopausal at 29 are not very enjoyable. And, you know, your ovaries protect your heart and bones and all these important things. And there's data to say that our young patients with ovarian cancer actually do better if we give them hormone replacement once we're done with surgery and chemo and everything.
Kristen, thanks for coming back and sharing the update. And we're so glad you've wrapped up with your treatment. What do you want the big takeaway from your story to be?
You know, listen to your body. You know what's not normal for you versus what is. And then for those who are fighting, keep fighting. You got this.
Great message. Dr. Jewell, what's the big takeaway?
Well, one, if you're having symptoms, again, and someone hasn't done a pelvic exam, get a pelvic exam. It really is important. And I think sometimes as women, we may feel uncomfortable advocating for ourselves in that way, but that's a big one for me. And then I also go and get treatment where you feel comfortable and supported. I obviously love where I work, and we have so many great resources here, and so I really advocate for that. You know, coming to a cancer center where there's physical therapy, there's onco rehab, there's dietitians, we have, you know, cancer-directed therapists, we have palliative care. So it's not just me, you know, I may be the captain of the team, but we have a whole group of people that are assessing everything, and I want every cancer patient to have that, right? I want you to go somewhere where you feel like if you're having a symptom, if you have something going on, that there's going to be someone on the team that's going to be able to help you with that. Because it isn't just curing cancer, it's you need to have quality of life during and after.
Great to see you this morning.
Yeah.
Thank you both. Thanks to both of our guests today. Thanks to our viewers for being with us. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update, faith, friendship, and an entire neighborhood are helping one young mom face breast cancer. I'm Jessica Lovell on the next Morning Medical Update. See who was there to help her through chemo, hair loss, surgery, and whatever comes next. Plus, how oncologists answer a patient's fear of a triple negative diagnosis. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.